I introduce you to the certificate course of surgery for MBBS resident, MBBS students. So this is a novel initiative by Highland Care Multi-Speciality Hospital, and we are actually going to train the residents in a lot of surgical procedures, in the bedside clinics, in the clinical skills. And today we have Dr. Anand with us, and he's going to give you a case presentation. This will not be a large or elaborative case presentation. It will be a very, you can say, comprehensive type. So we will be going for some important points for this patients, for our do's and don'ts, for all the residents. We are going to see how a case should be presented in a concise way. So Dr. Anand, can you tell me what is this case, and can you give me a brief summary of this patient?
Sure, sir. Good morning, everyone. Good morning, sir. So my patient, Santara Devi, 55-year-old female. She was admitted yesterday, that is 29th of October, and she was examined today, that is 30th of October. She is residing at Palam village. She came with the complaints of pain in abdomen for last 4 days, and she also has history of constipation for last 3 days. So in history of presenting illness, my patient was apparently asymptomatic 5 days back, following which she started developing pain in abdomen, which was gradual in onset and which was gradually progressive. She also complained of constipation. She didn't pass any flatus or nor the feces for last 3 days. So my patient, it was not associated with any kind of vomiting. It was not associated with any kind of abdominal trauma, or it was not associated with any kind of fever. So
basically, so he has given me a brief presentation of the pain. So what are the important points that you should be mentioning when we talk about pain? Remember, we have a mnemonic which is known as Socrates.
Okay, sir.
So you should tell me about the site, the onset, the character.
Yes, sir.
Then radiation, then associated features. Is it associated with any burning, like you told about the constipation? It's not associated with. It's associated with. Then timing, then exacerbating features, and then if there are some more relevant, you can say, features, you can add to that.
Okay, sir.
So you notice the pain 4 days.
4 days
the
back.
Patient has started with the pain 4 days.
4 days back. Yes, sir.
Now, can you exactly tell where the pain is?
So the pain is located in the periumbilical region and in the lower abdomen region.
Okay.
Sir, it was insidious in onset. It was gradually progressive. It was non-radiating type of pain. It is colicky in nature, and it was relieved after she had fast. She did not eat for a day, and she said that it was relieved after having it. One of the significant history which I found was she's having a scar. She told about getting operated last 30 years back, which was according to the history, I got to know that it might be because of rupture of intraperitoneal rupture of bladder, which she has underwent a midline laparotomy. So she has one of the findings, which is.
So now she has, according to you,
yes, sir,
she has acute intestinal obstruction or subacute features. What do you think? Whether it is a pain, since a periumbilical pain,
yes, sir,
can be due to stones. A periumbilical pain can be due to appendix, initial phases of appendicitis, because the root value of the appendix is T10.
Yes, sir.
So many a times the patient start with the vague periumbilical pain because of the irritation of the visceral peritoneum.
Yes, sir.
So is the pain static there, or after admission has the pain moved?
No, sir. The pain is completely static there.
Great. So this patient has a history of a surgery also that was done 30 years back. So what differential diagnosis can you make for this patient?
So the first differential I would think of is, sir, adhesion, sir. It is small intestinal obstruction. It might be due to adhesions. So that is the first thing which is coming into my mind.
So you are thinking that it could be a case of intraoperative adhesions. Yeah, post-operative adhesions, which you are seeing this. Okay.
Yes, sir.
Then can you show me some basic steps of patient assessment, patient examination?
So first we'll first take a proper consent of the patient.
Sure.
We'll make sure that a lady or her relative or one of the staff nurse should be present in case of examination. First we'll do the general examination, like we'll see if she is conscious oriented. Then we'll check for vitals of the patient, and then we'll proceed towards pallor, cyanosis, clubbing, lymph node.
Okay. I understand. We are not going to do that part.
Okay, sir.
So one thing, students, which is very important is when you are going, I'll ask you directly to go for the abdominal examination. So when you are doing a proper abdominal examination, or whenever you do doing any examination, the first very important thing is to take a proper consent from the patient.
Yes,
Patient's consent is very important. The second thing is the patient's abdomen should be in a relaxed posture.
Yes.
And for that, you'll ask the patient to use a pillow. Remember, when a patient uses a pillow, that relaxes the abdominal wall and helps you have a proper assessment. So let us try to, can you show us
Yes,
some basic assessment?
Yes, sir. So the assessment is done in 4 things: sir. Inspection, palpation, inspection, palpation, percussion, and auscultation.
Okay.
So, sir, for that we'll first ask the patient to flex her in the knees and hips. आप पैर मोड़ पाएंगे? ठीक है, वो भी मोड़ दीजिए. हाथ साइड में रखिए दोनों. Sir, we'll make sure that her hands are on the side also. It will also relax the abdominal wall. And then we'll expose her, sir, from the xiphisternum to the pubic symphysis, sir.
Ask.
So, क्या मैं आपके कपड़े ऊपर ले सकता हूँ? मुझे बस आपका पेट का एग्जामिनेशन करना है. थोड़ा ऊपर. Thank you.
Yeah. Thing that you will do is,
Sir, I'll first do the inspection. So I'll first check for generalized abdominal contours, sir, if it is distended, if it is. So then I will check for if there is any visible dilated veins, peristalsis present. I'll see if there is any mass or something which is obviously seen. I'll also check for hernial orifices if she is having. Sir, which is the right paramedian lower midline incision which they have taken. Sir, and we'll check for the umbilicus also.
Yeah, this is the scar of the previous surgery. You can see a paramedian incision has been given.
Yes, sir.
Okay.
So,
okay.
okay.
Okay. So there are two surgeries. One is the C-section, which has already been taken, and this was a classical C-section. And this is the phalansteal incisions, and this is the paramedian incision that we have.
Yes, sir.
So one hint that we get from a history, that she is strongly going to have a risk of obstruction because of the adhesions. Because of the adhesions.
Yes, sir.
What can you comment about the umbilicus? Can you comment?
So the umbilicus looks normal. It is shifted towards the left side, maybe because of the scar present on the right side, and it is inverted. It is inverted.
So what is very important point that you see when you see an inverted umbilicus? This is a normal umbilicus. This is normal umbilicus. Had it been inverted,
Yes, sir.
that would have been seen in
Ascites or sir.
Very good. What are the other important things you want to add to this inspection, and then we can go to the other inspection. Then,
Sir, as I'm suspecting this is a case of obstruction, I would first like to auscultate so that the vowel sounds won't be hampered because of my palpation.
very good.
Sir, I would first like to auscultate if you.
Okay, yeah. Can you just tell us the vowel? Can you tell us the right way to do the auscultation?
Sir, we'll auscultate in all the 4 quadrants of the abdomen, and we'll place the stethoscope for first 30 seconds to check any of the sounds present. We'll check the nature of it, whether it is dull, whether it is hyper resonant, whether they are normal, or if we are not able to see it within 30 seconds, we'll wait for another 30 seconds, and after 1 minute we'll comment on the sounds, sir.
Okay. So what is the most important thing when you are going for auscultation is, before you go for a 4-quadrant auscultation, generally you place, this is umbilicus, you place your stethoscope on the right hand side. Okay. You wait for 20 seconds. Get a vowel sound. Yes, you can extend the time if you get it after. The ideal time window is 1 minute. You should wait for 1 minute to get the proper vowel sounds. Now these vowel sounds are a very important guide. Once you get here, then you will assess all the 4 quadrants for that.
Okay.
So can you just check and tell us whether the vowel sounds are there? Is there?
Yes, sir. So vowel sounds are heard and they are hyperperistaltic in nature.
So what do we get to know if it's hyperperistaltic?
So basically, hyperperistalsis says that there is some distal obstruction. So the vowel is trying to contract hard to overcome the obstruction. So this is
very good. This is one very big hint which gives you a diagnosis that it could be a case of dynamic intestinal obstruction. Students, there are 2 types of intestinal obstruction. One is dynamic and adynamic. A dynamic has a mechanical obstruction. Now this could be intraluminal because of impacted feces, maybe because of stones, maybe because of bezoars, maybe because of intussusception. It could be intramural, maybe because of strictures, maybe because of tumors. It could be extraluminal because of the adhesions, which is in fact the most common cause here. Looking like,
yes, sir.
It could be because of volvulus, it could be because of hernias. Anything can happen. So the hyper resonant sound is the initial attempt of the bowel to push through the peristaltic, you can say, activity through the mechanical obstruction, and that is why she is having a hyperperistaltic. What else can you suggest? What else examination you will add? You have done the auscultation. What else?
So then I will do the palpation and then I will go for percussion, sir.
Okay. So do the palpation.
Sir, we'll palpate in two forms. Sir, firstly the superficial palpation in order to check any swellings over the abdominal wall. We'll also check for generalized tenderness or if she's having pain. Before that, I'll check the temperature of the abdomen. So for that, I like to remove my gloves. And I'll
You just do the assessment with the. Can you give her gloves? Can you just do the palpation?
Okay.
So I'll tell you about the palpation. When we go for superficial palpation, so when you go for a superficial palpation, you should be very gentle.
Yes, sir.
Can you see? You should be gentle so that you can appreciate all the superficial texture. Now, don't go for deep. Go for superficial palpation. Means superficial palpation.
Yes, sir.
So have you done superficial palpation earlier for this patient?
Yes.
So did you find anything?
No, sir. There was nothing significant finding except for the fibrosis of the scar mark, which I found on the superficial palpation.
Great. Can you tell us how do we go for deep palpation?
Yeah. So basically, deep palpation, she is not quite obese patient. So sir, even one hand would be enough, or else we would to use two hands for deep palpation. So firstly, we'll ask the patient where the pain is, and we'll start opposite to it so that it won't cause much of the discomfort to her pain. So sir, she's having a lower and left-sided type, lower left and right-sided type of pain. So sir, first go with the right upper quadrant or epigastrium.
Okay.
मैं आपका पेट पाल्पेट करूंगा. अगर दर्द हुआ तो मुझे बस बता देना. ठीक है?
So this is very important that we should be using the pulp of the fingers.
Yes.
The pulp of the fingers. You should not use the tip of the fingers. It should be the pulp of the fingers which you should be. And you can choose to go from clockwise to anti-clockwise. Yes. But yes, you should be seeing all the quadrants.
So yes, as we can see, sir, after placing in the left iliac fossa, she is wincing with pain.
Okay, so you can see that this patient is having a left iliac fossa tenderness. Can you have इधर दर्द है, इधर तो कम है, इधर दर्द है, इधर ज्यादा दर्द है. So she is having a left iliac fossa tenderness. Yeah. So okay, since this is discomforting for the patient, we'll not do a palpation for this because this is a case of subacute intestinal obstruction. What else would you like to your examination apart from this? Will you be looking for some ascites, etc.?
So yes, I would like to look for ascites, but there are no obvious signs on inspection. But still, I would like to look for ascites.
So how will you go for ascites?
So basically, the three tests. But in clinically, we would like to do two tests. Sir, one is the fluid shift, and the shift, and another one is the shifting dullness. Sir.
Okay, so can you demonstrate us the shifting dullness?
Yes, sir. I'll just demonstrate. Sir, first we'll start from the epigastrium. We'll start percussing towards the midline, and then we'll go to either of the flank. We'll check where if any dull note is present. If in case the dull note is present, we'll ask the patient to shift on the opposite side, and then we'll start palpating. We'll get a resonant note.
Oh, can you show?
Yes. दर्द हुआ तो बस बता देना.
There are a lot of techniques. Some people prefer to go from epigastrium to the hypogastrium. Some people prefer to go from right flank region to left flank region. Remember that you have to go for a sequence. So you have to follow the right to left or top to bottom sequence. So this is how the percussion is being done. So first of all, if we get a hyper resonant note, so whenever you are doing a percussion, you have to see the note. The character is dull because of the dampening that has been created by ascites, or it is resonant. Resonant means in case of ileus, in case of obstruction, the bowels are often distended. So did you find anything?
Sir, there was no dull note, but sir, I could find that there is a resonant note prominently over the right side than the left side.
There is one more method to demonstrate this. When you are actually percussing, the first thing is, like, if you're not having that much of time in the clinical practice also, you start with the percussion. Suppose you have done the percussion. And then you will ask the patient to आप उस तरफ करवट लीजिए. What is the advantage of this? Had the fluid been here, now because of the gravity, the fluid will shift on the other side, and the note will actually change. And this is again a very important thing that will tell you about the shifting dullness. One very important thing is, sometimes the ascitic content is not that much that it will be elicited. In that case, you ask the patient to take a knee chest position, and then we do that percussion. That is known as puddle sign. Yes. Otherwise, you can also demonstrate a fluid chill. Can you show me how we do a fluid chill?
Sir, I would like someone to place this.
Yeah, I'll do that for you. So we place the hand. Yeah. Yes, we place the hand in the mid.
So then we'll place one of the hand here, and then from either we can just tap from here, or else we can just push from here. So and we'll feel thrill on the other hand, sir. If there is fluid,
You can show it from the other side so that it can be recorded here.
Yes,
So
sir.
we can shift it, yeah, and we can feel
Yes,
it
sir.
on the other side. That thrill is
Yes,
spread. One more test is a succussion splash.
Okay, sir.
Do you know how we perform a succussion splash? You will take this. You will
Yes, sir.
take this stethoscope, and you will put the put the bell at the level of umbilicus. Hold it like this,
Yes, sir.
and shake it. If there is a water bottle like shaking sound, a half filled water bottle will always have a water shaking. This is what is known as a classical succussion splash. So leave it. Since this is a concise discussion,
Yes, sir.
we will have a discussion on the patient's case.
Which is supine and erect, abdominal X-ray, supine and erect, and also, sir.
So what do you want to look in a supine X-ray? What do you want to look in erect X-ray?
Okay, sir. In the supine X-ray, actually, you want to rule out the location of the obstruction. We would be able to
Very
rule out
good.
the supine X-ray.
Very good.
Sir, and the erect, we'll get to know of pneumoperito.
Very good, very good, very good.
With
One
perforation.
very important thing that I am going to tell. When we order for X-rays, these X-rays are straight X-ray. What do you mean by straight X-ray? It's a non-contrast. Straight doesn't mean the straight posture. It's a non-contrast X-ray. So straight X-ray, erect view is to see two things: perforation and second the air fluid columns.
Yes, sir.
More than 3 air fluid column with a functional profile of a patient showing you pain, tenderness, constipation, obstipation is diagnostic of obstruction. The second thing is the preferred investigation is abdominal X-ray straight, and it should be supine view to see the. So have you done it?
Yes, sir. We have got the X-rays. And
Okay. Apart from that, what else? What other investigation? Supine X-ray of this patient. This is the supine X-ray of this patient. Can you see a classical transverse line? You can say a loop. Yeah, this is
Yes,
a classical transverse line loop here. This is again here. Now, if you see the patient is having pain and tenderness over the left. Can you see a dilated colon,
Yes, sir.
transverse colon?
Yes, sir.
These are not continuous. Can you focus on this line?
Yes.
These are interdigitating.
Yes, sir.
This is what is a classical profile of a colon. A colon is interdigitating.
Okay.
And a small intestine will have plicae circularis or
Yes, sir.
valvulae conniventis. When we
Yes,
talk
sir.
about valvulae conniventis, they are concentric rings. They are concentric rings. So can you see this is loaded? This is here. There is fecal impaction.
Yes, sir.
Here there is fecal impaction, and then this is a swollen transverse colon. One very important thing: this is not a small intestinal obstruction.
Yes, sir.
Why it is not a small intestinal obstruction? Because there is gas in the colon.
Okay, sir.
So one thing is that this is a large bowel obstruction.
Yes, sir.
Now, what could be the cause based upon this? It could be colitis.
Yes, I
Colitis in this age group is very common. Let us see the erect posture also, erect view also. You can see a classical air fluid column here.
Yes, sir.
Not too many air fluid columns is one air fluid column I can appreciate. Yeah, one air fluid column. There is a small air fluid column here also, but it is not appreciable. But you have a stool being impacted over this. Now I want to tell one or two things. Whenever we talk about the X-rays, had it been a small intestinal obstruction, this profile would have central transverse loops. And
Yes,
that is what is a classical step ladder appearance. That's a classical step ladder
Yes, sir.
appearance which you are not having in this.
Yes, sir.
So this X-ray shows you a classical large intestinal obstruction of subacute category.
Okay, sir.
What else are you thinking what else investigation can you be ordering for this patient?
Sir, I would like to get an ultrasound done. Sir, just in order to rule out any ascites which I could not be able to do illicit clinically.
So did you get an ultrasound done?
Yes, sir, we got an ultrasound done. Sir, ultrasound is suggestive. Of the distal ileal loops, which are prominently seen on the ultrasound, and they are also saying about the sludge in the gallbladder and thickening of the gallbladder wall. So, sir, one more differential I would like to strike in my mind. It can be an obstruction because of gallstone ileus, sir, but it is a rare possibility.
Very good. This could be a possibility because an elderly female presenting to us with recurrent, you can say gallstone, you can say like symptoms, and with sudden onset of intestinal obstruction, this could be a gallstone ileus. But actually, had it been a gallstone ileus, we would have other history. The patient would have at least tenderness around the right upper quadrant. But in this case, if the patient advances to a state of acute intestinal obstruction, you might miss it. I am a bit, you can say, more conservative in making this diagnosis,
Yes, sir.
because this pain is on the left side.
Left side.
Most of the time, if a stone is able to cross the terminal IM, it will cross.
Yes,
It will cross. It is not going to get impacted in the terminal IM. So the chances of gallstone ILS is less. Yes, it could be a case with acalculous cholecystitis, maybe acalculous cholecystitis, or it could be a case of cholecystitis if you take the GB sludge. Since the sludge is present according to Tokyo guidelines, it could be taken. But right now, this patient has two problems. One is the subacute intestinal obstruction, and one is the acute cholecystitis because of this.
Yes, sir.
So what would you like to go for? Tell me, what management will you follow for this patient, for subacute intestinal obstruction patient?
Sir, keeping in mind the adhesions, so this is the only case where I would like to first do conservative management by inserting a rice tube.
Very good.
We'll make the patient NPO and we'll take her on IV fluids.
Very good. Very good. Most of the times, the patients do get managed with this conservative attitude. And if it doesn't, and if it progresses,
yes, sir,
to frank obstruction,
yes, sir,
if you see this patient within 2 days, whether this patient has deteriorated or has improved in.
So the patient has actually improved. She has passed flatus today. So, and our bowel sounds are also getting.
That's great. So that means the conservative regimen has actually worked for this patient. So the conservative regimen includes the supportive fluids, the decompression of the gut, and this is what is all. And then what will you be doing for this acute cholecystitis? Will you be planning a surgery for this patient?
Yes, sir. But sir, as 72 hours have passed, I would like to wait for another 4 or 5 weeks so that the inflammation resolves, and then we can go for an elective laparoscopy.
This is great. But let me tell you, the Tokyo guidelines 18 have updated this concept, because there was a fight amongst the consultant that whenever a gallbladder comes, they never leave it.
Okay.
So with the Tokyo guidelines 18, the rule came that earlier that it was first 5 days.
Yes, sir.
After that it came 10 to 15 days. If the patient presents, you can do.
Okay.
And now it is, if a patient presents with acute cholecystitis,
yes,
irrespective of the time, if the center is an advanced laparoscopic center, they can do it anytime.
Okay.
So yes, as of now, as at MBBS level, yes, you should know this. First 5 days are very crucial. If the first 5 days have passed, you should try to do an elective. Otherwise, yes, you can carry with the laparoscopic cholecystectomy, depending upon the expertise of the consultant.
Yes.
So this was a small, you can say, case presentation, and this is a hint of how the certificate training goes on. We do a lot of ward rounds, we do a bedside clinics, we do the simulation based practices on endo trainers, and yes, you get a chance to attend the OTs, assist them. So this is one of a good initiative for all the B.B.S students, and do join. And for information, you can log on to www.drsaurabhdixit.com and just secure your seat. So till then, bye bye. Hope you people enjoyed the class.